This podcast is a production of OPENPediatrics, an open access online community of healthcare professionals sharing best practices from around the world. Visit openpediatrics.org for more.
Hello and welcome to the World Shared Practice Forum. I'm Dr. Tracy Wolbrink, a pediatric intensivist at Boston Children's Hospital and co-director of OPENPediatrics. Today we'll be discussing collaborative care models for hematopoietic stem cell transplant patients. I'm delighted to be joined today by teams from the US and India. I'll start by introducing my colleagues from Boston Children's Hospital. Dr. Adrienne Randolph is a pediatric critical care attending at Boston Children's Hospital and a professor of anesthesia and pediatrics at Harvard Medical School. She, along with Dr. Leslie Lehman, has started our collaborative care model at Boston Children's Hospital.
Thank you for inviting me, Tracy.
Dr. Leslie Lehman is a pediatric stem cell transplant attending, and she's in charge of quality and education for her department.
Thank you. It's wonderful to be here.
Dr. Revathi Raj is a senior consultant in the Department of Pediatric Hematology and Oncology and Blood and Bone Marrow Transplantation at Apollo Cancer Hospital in Chennai, India.
Thank you so much. It's such a pleasure to be here today.
Dr. Indra Jayakumar is the lead pediatric intensivist at Apollo Cancer Hospital in Chennai, India, and co-convener of the Indian Academy of Pediatrics Pediatric Transplant Critical Care Program in India.
Thank you, Tracy, for the invite. Delighted to be here.
Dr. Amy Tellor is a pediatric stem cell transplant attending in the Department of Bone Marrow Transplantation and Cellular Therapy at St. Jude Children's Research Hospital.
Thank you, Tracy. I appreciate the opportunity to be a part of this.
And Dr. Asya Agulnik, an associate member in the Department of Global Pediatric Medicine and Division of Critical Care. She's also the director of the Global Critical Care Program at St. Jude Children's Research Hospital.
Thank you so much, Tracy. It's great to be part of this group.
Fantastic. Well, we have quite a powerhouse of many impressive collaborative care models all around the world. And I'm really excited to learn from all of you today. And hopefully our listeners will also get some insight into the current state of our collaborative care models and why they were started, what the structures look like, and maybe some advice for them to take home and continue to improve their collaborative care models. So maybe to set the stage, Dr. Randolph, you obviously have been instrumental in leading this effort along with many colleagues through the policing network. And I'm curious if you could give us a little bit of history as to, why this was such an important thing to do and, how this collaborative care model began to come to be.
Yes, thank you, Tracy. So back in the late 90s, early 2000, the number of patients getting stem cell transplants was going up. And unfortunately, once they came to the ICU, the outcomes were really poor and mortality was very high. In fact, this was our highest mortality subgroup of patients in the ICU. And there were a lot of issues that led to the mortality being so high, but a lot of it was due to lack of collaboration between the ICU and the stem cell transplant experts. And by the time they got to the ICU, the patient was in somewhat dire straits. So Leslie and I at the Pediatric Acute Lung Injury and Sepsis Investigators Network joined together and invited from each center that had at least 20 transplants a year, a bone marrow transplant specialist and a critical care specialist, and tried to create teams to try to look at the outcomes and figure out what's going on here, how can we make it better? And at our own center, we started an entire QI process that we'll describe in more detail later to try to improve the outcomes. And we started collecting data and working together and really just talking about so that we both understood things from each individual's point of view, them as the expert in the transplant and us as the critical care expert, trying to build a more collaborative care model of helping the patient recover.
That's great. And I wonder, thinking about what the scene looked like perhaps in India as why you also started to develop the collaborative care model.
So thank you for this question. I think our transplant program started in 2002, and I was trained in the UK. And as part of my training, I did 6 months in Bristol at the PICU first. And just as everyone's experience, the transplant-related mortality was high if they came to the ICU. So that's the first thing I learned. And after coming here, we are a standalone cancer center. The Children's Hospital is 5 kilometers away. And every time a child became sick, to involve the PICU team, it was quite a big challenge. So I found that running a transplant service was difficult. And with time, from 2002 to 2009 and 2012, we started the cord transplant. And this was the most challenging time because they were small babies, and cord transplants taught us a lot of things, including cytokine release and how to deal with multi-drug resistant bacteria, fungal infections, opportunistic infections. And it was very clear that this is not something we could pull off on our own, and we needed a team and the team to be on site. So our on-site team, despite several appeals, only started in 2012. So it was clearly, it made a difference to patient service, to our own team, our nursing team. And this is a model definitely that we would recommend to every other unit, because the patient-centered service is the key. And if we, in transplants especially, if we prevent any problems, then the outcomes are better, because we have to do early recognition, prevent clinical deterioration. And all of this happens when we round together. And it's been an amazing journey from our first cord transplant in 2007 to the number of haploidentical and complex and challenging cases we are doing today.
Thank you so much, Dr. Revati. Dr. Indra.
So just further to what Revati has mentioned, my experience and my marriage with my hematology colleagues, the experience in onco-critical care unit over the last 6 years has been rewarding and a steep learning curve, helping me understand the needs of these vulnerable children. From the PICU perspective, we have realized that managing a pediatric HSCT patient poses unique challenges due to so many other underlying comorbidities. It is much more than just managing the ABCDs. We require the expertise and guidance of our hematology colleagues. For example, GVHD immune suppression or TMA treatment should go hand in hand with ventilator and sepsis management. And we are constantly learning from each other. The hematology oncology team, also called the HOPE team, they know that recognizing sepsis and septic shock in HSCT children can be challenging. They may not have the classic signs of fever, drop in sensorium, oliguria, or even a tachycardic response to low blood pressure. Since many are hypertensive, there can be delays in recognizing septic shock on the floors. This mutual learning has really helped improve our outcomes. And we started this collaborative model around 6 years ago to understand the unique physiology, the timeline of complications, considering each child's vulnerabilities, and ensuring continuity of care. I think this is crucial for achieving positive outcomes.
Thank you so much. I think there's so many things that you said that resonate so highly with all of us, I think, in terms of the complexity of these patients. And, you know, as Adrienne and Revati mentioned, you know, the higher incidence of mortality and morbidity of these patients makes it really challenging. Now, I'm curious, you know, at St. Jude, being a pediatric cancer hospital, I'm curious how, you know, the start of the collaborative care model was there. Was it different? Were there any other factors that either Amy or Asya that you guys considered?
Yeah, thank you so much. And as you mentioned, our hospital is unique. We are dedicated to children with cancer and other catastrophic illness. So that's blood disorders, infectious complications, and neurologic disease. But the majority of our patients are children with cancer, and many of those require stem cell transplant. Our ICU is dedicated to those patients. And as Adrienne mentioned, the highest risk patient population for sure are children who have received transplant or cellular therapies. And so a lot of the challenges that we face are actually quite similar, despite the uniqueness of our hospital, as everything you've heard from the other presenters. And I think the motivation for us to really have a co-management model between the ICU and our transplant team are very similar to the reasons why those models developed in other centers. As the number of children who receive transplant increase, also the increasing complexity of the patients themselves. Often we're dealing with patients getting their second or third transplant, potentially having other cellular therapies with evolving complications of those novel procedures as well. Also, as our services grow, the number of individual providers that are taking care of patients also is increasing. And so while if you have two people, maybe you can have that mind blend where you know exactly what the other would say as your teams get more complex, you really need that co-management in order to make sure everyone is aligned, as individuals might differ in their specific management. And so really this is a way to ensure the best possible care for our patients, to make sure there's consistency regardless of which providers are on service, and that there's really group decisions being made in the best interest of every patient that develops critical illness.
That's great. And Amy, I wonder if you might tell us a little bit about what does the structure of your collaboration look like, rounding or any educational models? Like, how does this work at St. Jude?
Yeah, I think to make a collaborative model really successful, it is multifaceted, like you just alluded to. So there are kind of the standard where the transplant team goes to the ICU and we do family-centered rounds together. And so we have our entire transplant team comes to the ICU so that we have our nurse practitioners, our infectious disease colleagues, et cetera, that are all there together making these decisions. I think additionally to that, we have done a really good job of trying to incorporate the ICU in some of our transplant specific meetings, for example. So for our inpatient handoff that we do once a week, if we have a patient in the ICU attending or nurse practitioner really tries to attend so we can again have robust discussion in that moment. I think we also have a great model for our rapid response team and kind of other early assessment of patients on the floor. And to me, that's one of the biggest things that I've seen over the last few years that's grown tremendously. So we're having day-to-day, sometimes hour-by-hour discussion with our ICU colleagues at the bedside on the transplant unit, trying to do things that might prevent them from going to the ICU or early management that will make that transition smoother, even if we know it inevitably is coming. And then I think one other aspect to our program that is unique is that we've, over the last few years, have started having some conversations about our really high-risk patients before they're even admitted for transplant and cell therapy. And so we have one attending in the ICU who is dual trained in Hem/Onc and Pediatric ICU. And so she will consult on these patients outpatient as part of their pre-evaluation time period to really dive deep into their history, their course, understand, learn about them, counsel our team on what we might be able to do now to try to prevent some of their highest risk complications. But at the very least, can go back to the ICU team, talk about these patients so that we have some of that pre-knowledge before they even get to that team.
That's really incredible and super helpful, I think, to have that insight as to these are the patients that are expected, what are we going to do, and having that plan in advance. That's excellent. I wonder, Indra, if from your model, if you could describe a little bit of, what that looks like at your hospital. I imagine there's some similarities, but probably some differences. And I'm curious to hear a little bit more.
Sure, Tracy. So the onco-critical care team in our hospital extends the support beyond the confines of the PICU. As Amy mentioned, we do co-round on the wards and the BMT unit and are actively involved in shared decision-making with our hemato-oncology colleagues. We've learned that time is of the essence in managing clinical deterioration events, CDEs, and early recognition, timely PICU intervention on the floors can make all the difference to outcomes. And if you don't mind, I wish to share to the group our exciting data of our 10 years outcome study. We compared 10-year overall onco-critical care PICU outcomes over 2 5-year periods, 2014 to 2018 and 2019 to 2023. In the first 5 years, as Dr. Revathi mentioned, the consultant intensivist from the general PICU rotated in the satellite oncology PICU unit, with the fellows changing frequently. The team dedicated to onco-critical care was established only in 2018, and PICU interventions, including inotropes, were initiated on the floors for clinical deteriorating events to prevent care delays due to bed non-availability, etc. And patients were later transferred to the PICU. Comparing the 2 5-year periods, 2014 and 2019, our statistically significant findings are very gratifying. The most exciting was the significant decrease in PICU mortality from 22 to 14%, despite an increase in transplant numbers. Even more interesting was a decrease in the need for mechanical ventilation within 12 hours of admission to the PICU, a decrease in mortality within 24 hours of PICU admission, suggesting we are intervening early. Notably, there was a significant reduction even in invasive organ support interventions such as mechanical ventilation and renal replacement therapy. And to us, in resource-limited, reduction in organ support translates to lesser financial burden to families as well. And this is something we know HSCT journey is a marathon, not a sprint. And in addition to good outcomes, one has to consider the cost to the families in resource-limited settings. And I think we talk about the first hour of the sepsis bundle. For us, precious time is lost if we wait for the patient to be shifted to the PICU, and they deteriorate very rapidly. There's delay in getting the perfusion pressures right, etc. And then after that, it's just a downward spiral of multi-organ dysfunction, more interventions, escalating expenses, worsening outcomes. So we have realized that intervening in the crucial golden hour, and that could mean on the floors as well, that has made a lot of difference to the outcomes. So that is a credit to the communication that we have with the hemato-oncology team, multidisciplinary inputs, and close collaboration.
Thank you for sharing that. And that is really impressive data. Super exciting to hear how you've been able to make those positive changes in your community. And, you mentioned that, a lot of it is with collaboration. And I'm curious, just one quick follow-up question. What were some of the factors that I think led people to start calling you early, start trusting in, you to come out and help manage that? And I'm curious a little bit of how that went.
I think, as mentioned earlier, if we have difficult cases and we know we're going to anticipate problems during transplant, so even before we start the conditioning, we discuss these cases with Indra's team. And what really clicked is that when the two lead clinicians show that they are respectful of each other and understand each other and are able to accept and implement their advice. So the whole team starts that. So it's with the fellows, with the nursing, and the entire team works together. So I think definitely we will have some differences of opinion in management. So if we have protocols, so that's what we have been working on, to have protocols together. What are we going to do for hypertension? When are we going to shift from the floor? Is it on one inotrope or two inotropes? Who are the ones we are worried about? And what do we do for these patients? And I think being respectful of each other's professional inputs and working together as a team, I think that's what we have learned. And that's useful for us because it prevents burnout in the physicians and in the nursing team and everyone. And it's also a great boon for the patients to help reduce costs for them. And we are seeing the more complex transplants we do, we are doing very little babies, 2 weeks old, 4 weeks old, and the teenagers who come, as mentioned earlier, second transplant, third transplant, CAR T cells. So there is so much we need to learn. And what to expect with the complications, we need to communicate it with the hemonc team. And I must say that Indra knows more hemonc than I do.
I'm hoping to shift a little bit to here, just to kind of tidy up this a little bit more about the Boston model. And I wonder, Leslie, if you wouldn't mind kind of explaining a little bit of what the collaborative care model looks like in Boston.
Thank you. So I think people have outlined very clearly and accurately that these are incredibly complicated patients that have a high likelihood of getting critically ill. And so it's a good place to sort of direct your efforts. I think there's the medical interventions, identifying them early, having the doctors and nurses and other support team members, be in a collaborative mode. But we have also really focused on some of the psychologic hurdles. And Adrian will know that in the past, before the Polizzi network started, which really twice a year brought people from the critical care field and the bone marrow transplant field together for a meeting in a room, the sort of extreme version of the model was that the intensivists felt like we never knew that a patient wouldn't make it, and we could never, ever change goals of care or even have a conversation with the family about the fact that the outcome may not be good. And our stem cell transplant, concrete extreme version was that the ICU, gave up or thought that we pushed too hard. And I think it led to a lot of misalignment of goals that played out for the family and the nursing staff, particularly. We were maybe a little oblivious to it at the physician level, but I think it really was hard for them. And so a lot of the efforts have been directed to that. One not planned, at least by me, was just being in a room together for several days a year and having honest conversations really helped. And then a new model that we have that was really led by nursing, both in BMT and critical care, is called an enhanced care model, where patients that are in for a long time, which also often correlates, but not completely, with not having a good outcome. And it's really in the ICU for over 7 days to not capture the kids that come in and out quickly for a surgical consult or something like that, and that are on the bone marrow transplant unit for longer than 6 weeks, are labeled as enhanced care. We meet about them monthly with representation from ICU and critical care, and we troubleshoot. They have more family meetings. We try to make sure that the goals are aligned, that everybody's being heard. We had family meetings, but we've also started having meetings without the family, just the different care teams, so that in a very free space, nursing, young physicians mostly, can say, this feels like we're hurting the child, or we can say, it feels like you've sort of given up, and these are the reasons we still have hope. And there's never a right answer, but it's just getting us all on one page. And that has made it feel like a true collaboration, and I think really helped psychologically all the people that do this difficult job.
I love that. So thank you for sharing that. I think the last two kind of discussions about psychological safety are huge. And I do feel like that's also something that we've seen change over time, though without the formal efforts that you just described, Leslie, which truly are incredible. Like, we often will have the family meetings and care conferences, but not as early as you're describing and not as proactively, which I think is a next step that programs may not think to take. So the fact that you guys are doing it and it's working well, I think is really amazing and kind of inspiring for those of us who are trying to build these programs.
Thank you. It takes a little, you have to get everybody on board. And I remember the first time, I'd had an hour and a half family meeting, and then the nurses reached out and they're like, we would love you to meet with us. And I was like, oh my goodness, like, how many meetings in a day? And it was the best hour I spent in my entire month of service. So when you see that, and then the next days were so much better, it was like, well, this was absolutely the most valuable thing I did with my time.
That reminds me of a code situation. We talk about 15 seconds for 5 minutes. You get everybody on the same page. You sort of come up with your plan for the next bit of time, and then everyone can get behind it, especially if you bring everybody there. Everyone has the voice, everyone has an opinion, because each one of us brings something, unique to the table that we can all learn from. And I think hearing that over and over from every single hospital, that part of the success of these models was getting people in the room, talking together, sort of figuring out what the bias is, what different lenses we're all bringing to this table, and sort of just getting them out there and open along with the multidisciplinary team. And so I love that, no matter where we are, it seems like a lot of the same things have been effective, which was exciting for those that are looking to kind of build these models elsewhere. So thank you all for sharing that. One thing I also wanted to touch on that I heard from many of the programs is sort of the early communication, early conversations, early sort of interventions and transfers. And Asya, I'm wondering, you obviously have done tons of work in early warning scores and early transfers. I'm wondering your opinion sort of related to that, and what are some steps that hospitals can do to kind of enhance that space?
Thanks so much for pointing that out. I did hear that come up in all 3 hospitals, the importance of ICU outreach and working early to identify deterioration and potentially prevent critical illness or need for ICU, or transfer a patient early if the need is there. And I think that's super important to the care of these patients, regardless of what the setting is. The question, of course, is how do you encourage that? How do you create a process where that's normal and normalized and part of the routine care rather than once in a while? And so a lot of hospitals have had success using pediatric early warning systems. And so that would be a scoring tool that's typically paired to vital sign assessment as part of routine care, and then an action algorithm that guides the clinical team on the ward of what to do if a patient scores high or has deterioration. We use a Pew's tool that was actually developed in Boston Children's. It's been validated in children with cancer and post-transplant to identify critical illness, and has been used in high resource settings like ours, but also in a variety of resource limited settings in the world, and has been shown by our team to reduce deterioration mortality across those settings, among other benefits. A lot of those psychological safety, the teamwork benefits, where you're bringing a multi-professional, multidisciplinary teams together, including the family, in a conversation around deterioration and what the best steps forward are, which I think is the mechanism for how many of those positive patient benefits are realized, as well as creating a better team environment. So for us, it's protocolized. Patients on the ward, all patients, will get a Pew's score calculated with every set of vital signs. For us, that's every 4 hours in a stable patient. It increases in frequency if the score is high. In many hospitals that can't do every 4 hours vital signs, it's every 8 hours, and that works just fine. The data we have is that the score elevates 12 to 24 hours before the development of critical illness. So as long as you're doing it frequently enough to give warning, And then a lot of people focus on the score, but actually, I think the most important thing is what you do with an abnormal score. And so that's where it's a system and it has to have that action algorithm that's also integrated into the routine care. The details of the algorithms are really specific to the hospitals, meaning what are the processes to escalate care for a specific patient. It could be a call to an ICU. It could be a rapid response team. That's what we have with an ICU consult. And then the clinical decision is made based on the individual patient. It doesn't protocolize the management. It brings the providers to the bedside to have a conversation about what is happening, what can be done to mitigate, and what would be the right next steps. And that includes all members of the care team, including nurses and physicians and the family, of course.
Wonderful. And I wonder, Asya, where, if someone's interested in learning more about these early warning scores or trying to find them, is there anywhere that they can go and sort of look to at least get started?
Yeah, so thank you. Everyone is welcome to contact me in our Global Critical Care program. That's globalcriticalcare at stjude.org. We support Pew's implementation program. It's a quality improvement collaborative to support Pew's implementation in hospitals globally, including in Latin America, but also in English-speaking countries worldwide and Portuguese-speaking countries. So 3 different programs depending on language. And we invite centers to join annually. So if that's something that somebody's interested in learning more about, please reach out. And we're happy to provide all the resources. Much of that's published in open access, but also to provide information about the collaborative.
Thank you. And you had mentioned quality improvement as using the early warning score system. And Adrian, you had mentioned this early on, using the data to help inform and sort of help improve these collaborative care models. You obviously are doing a ton of work both here at Boston Children's as well as within the policing network. And I'm curious if you can speak a little bit to how data can help inform your models and maybe what are the hot topics that people are thinking about and talking about in the policing network right now.
I think that it's very important to collect data and to look at data both retrospectively and prospectively to understand what are the drivers of the poor outcomes, because if you make assumptions, you might be wrong about what are the complications. And so across the policing network, one of the things that we worked really hard on is understanding acute respiratory failure and understanding what are the rescue strategies that people are using, what's working and not working. And one of the things that we found out at Boston Children's with our data was that putting patients on non-invasive and cranking up the pressures and the oxygen and leaving them there is a really poor strategy, because eventually they're going to completely fail. And at that point, probably arrest when you try to intubate them. So we developed a non-invasive ventilation protocol that escalates based on how the patient's doing. And we have things where it says, please intubate. And it implements a lot of communication between the respiratory therapists and the caregivers so that we try to avoid those episodes where things were prolonged too far. We also try to implement diuresis, and if someone has occlusive disease with a lot of ascites, put peritoneal drains in early. So we try to do things to avoid intubation with fluid management and managing if someone has a lot of ascites that's competing, but at the same time using the non-invasive protocol in a way that is very explicit, and we can constantly test how's the patient doing. If they're not doing, rescue them.
Thank you, Adrian. I think these are beautiful examples of taking your data and, as you said, trying to understand the reason and the rationale why, so you can develop protocol and a procedure practice change that can really change those behaviors and change those outcomes. I'm curious if anybody else has any ways that they have done that.
We looked at our data with the children who are on calcineurin inhibitors and hypertension. So because our transplant unit is a mixture of both adult and pediatrics, it's not a dedicated unit. So for every age group, what is the standard blood pressure? So we audited our work to see how much the nurses are able to pick up what is hypertension and when to inform, so that we can prevent press and seizures and letting the child get intubated and ventilated. And it was an amazing exercise because we use that data to have a protocol for hypertension. So especially when we are doing infants with immune deficiency or the Fanconi patients who have renal issues, we saw a lot of hypertension with calcineurin inhibitors or when they went on steroids. So at the moment, just with this data analysis and having the protocol to treat hypertension, we use infusions of labetalol and sodium nitroprusside in the unit to prevent hypertension-induced emergencies and press. So this has reduced the press rates from 24% down to 12%.
Thank you both for sharing those examples of really using data to impact practice. And it's exciting to hear the positive changes in patient outcomes that, we're seeing through all of these methodologies. I want to ask one question. We're learning a lot about these patients in each of our hospitals. And for those of us that take care of these patients a lot, we gain a lot of knowledge. I think, Asya, you may have mentioned that, it's really hard to get everybody on board, and part of the rounding process has been a way to kind of change this sort of group practice. And I'm curious, are there other ways that in any of your hospitals that you're helping to either select the providers that are on these teams or train those that might be on call or taking care of these patients when perhaps they aren't able to join those rounds? And has there been any successes that anybody is willing to share with us? Because I think that that's a challenge as our units get bigger and, we get super specialized in the care that we deliver. There are other providers in our units. And how do we ensure safe care that's being delivered at the same level with all of the providers we have?
In Boston, we have 2 teams in the ICU, and for a long time under Adrian's guidance, we have had the BMT patients admitted just to 1 team. So already now you're down to 50% of the providers needing to know these issues. And I think that has worked really well. The other thing is we have a monthly meeting that the core providers from both teams come to, and we discuss all of the patients that have been in the ICU over the past month. Were there issues? Nursing attends that as well, and also have didactic sessions as part of it, where someone will talk about GVHD or TMA or some of the odd transplant related things that other intensivists may not be so familiar with. And every once in a while, I try to have it be so that we learn a little more about high flow ventilation or that things that we don't know. It's less important because we're not managing the vents as transplant physicians, but it's still, I think, good to have a fundamental knowledge of the care that we share.
In our unit, we have a WhatsApp group where we have the hematologists, the nurses, the intensivists, all sharing. So all the update, the vitals. So it's round the clock. Everybody is in the same page, and then we discuss, what best to do. So that, ensures we give 24/7 same level of cover. It is a challenge because it's such a niche. Oncocritical care is such a niche specialty. Getting the same, level of care right through day in and day out, 365 days is a challenge. So our unit has been recognized, fortunately, for the Pediatric Transplant Critical Care Fellowship Program. So that helps. So we're having fellows rotate and, taking, as Leslie mentioned, didactic classes. So we do attend the fellows, the intensive care fellows attend the hematology classes, didactic classes, and vice versa. So that really helps. And co-rounding, as Dr. Revati mentioned, there's flagging of all the high-risk patients. Even before the transplant, the pre-transplant stabilization is done with the intensive care team. So even maybe HFNC in the wards, monitoring patients in the BMT unit during the conditioning period, and anticipation of, serious events. So they would say they are giving a particular drug, or this child could get CRS, allo fever, ATG reactions, etc. And I think this co-rounding and sharing concerns, communicating, that really helps.
Yeah, I think this is a really important point that as our teams get bigger and complexity grows, how do you maintain that same level of care? And I think you've heard multiple strategies. Well, I will say for St. Jude, in addition to what Amy mentioned with intensivists joining the weekly transplant rounds, conversations between all of the division, if there's a critically ill patient, which almost always there is, we do have weekly meetings among all of the critical care providers who are discussing all of the patients in our unit, but really focusing specifically on the more complex patients. And that allows not just the attending on service, but everybody to weigh in and to learn about the patients so that we can co-manage them together as a unified team rather than having plans change every time a new person comes on service. And I think that as the field develops and it becomes broader, we have to let go of this idea that one person could be the knowledge of all the things that may go wrong. And I think that's true for all elements of critical care, but particularly true for these areas where there's just evolving evidence constantly, and it's impossible for any one person to know everything. And for the benefit of the patient, it's actually much better when it's a team, adding their unique expertise and perspectives and experience, and then coming to a shared decision. Theoretically, that makes sense. In practice, that's sometimes hard just because of time and other things. So there's strategies to kind of encourage that team-based approach and team decision-making. But a lot of that's just accepting that you as an intensivist or you as an oncologist are not enough for the complex patients. You have to have other perspectives. And that's better for the patient. That's not a failure of you as a physician. And that's going to only grow as the field develops. And there's so much more knowledge to inform the care of these patients.
It also helps in counseling families on a day-to-day basis, hand-holding the families together. So having the intensivist and the hematologist together counseling families, the families also feel a lot more reassured and safe, that everybody's transparent and in the same page.
I just want to say thank you to the six of you for joining me today and sharing your incredible wealth of knowledge. I think the models that you've presented, the advice that you've given, the willingness to share what's worked, the collaboration that you've produced within your teams to have open conversations and really work together is astonishing. And the patient care outcomes that you've shared with us today that have improved is really proof of these models being effective and important. And I'm hoping to do just a quick round robin and ask each of you for one piece of advice that you might share with others that are looking to either develop similar collaborative care models at their institution, advice that something that you think is super crucial to making these successful. And maybe Leslie, I'll ask you to kick us off.
Thank you. I think still sort of sticking with the psychologic, although the medical is obviously equally important, is I think we all have developed antenna about when things are starting to go off. There's a certain feeling of tension on rounds. There's a certain, what do you call it? Saying, the ICU people or the transplanters, grouping people and intervening really early. And usually I would start with the other attending and saying, it just feels like there's tension. And what I've figured out in life, for better or for worse, is that it should be easy when everybody has the same goal. And everybody wants the patient to be better, 100%. It's hard when you're trying to leave a job and they want you to stay and you want to leave, or vice versa. The goals are different. So that's a complicated situation. But in this situation, everybody has the same goal. And if you come back to that, and the parents have the same goal, nursing has the same goal, respiratory therapy has the same goal, come back to that shared goal and talk about it early, I think that can keep things from getting bunkered in a place that it's hard to get back from.
Thank you. That is incredible advice. And if we all could do that every day, imagine, what the care would look like. So that is fantastic. Amy, I wonder if you wouldn't mind going next.
I think a theme that we've heard throughout this is education and then re-education. So our teams change, new members come, data changes. And so I think we do a good job of that initial education push, but I think where ourselves included sometimes are lacking is the re-education and bringing it back up and just having ongoing conversations like that, I think are key to continuing this collaboration and tight-knit group feeling amongst the teams.
Fantastic. Indra, how about you?
So what have we learned from our HSCT patients in the last 10 years? That despite challenges, despite resource limitations, good outcomes are possible. And I think with shared decision-making, catching them, catching them early and intervening in the golden hour can make all the difference to outcomes. And that is only possible with multidisciplinary teamwork and close collaboration.
Thank you. Adrienne.
Well, I think on a practical note, one thing that we did that really helped build the collaborative care model is to round at the same time every day, put the patients on the same team, and go through the stem cell patients serially with the stem cell expert, as a partner in a structured rounding way. So we're covering all of their issues and our issues, because some of the things that they're checking off, we wouldn't usually cover, and the same with ours. So I think that was essential, and it's if people are trying to build this model, would be a first step.
Great, very practical advice. Thank you. Revati.
I think the whole point of this discussion is to show that there shouldn't be any more stigma against shifting a transplant child into the PICU. And we have worked 20 years to get to this stage, and any new transplant physician who's thinking of setting up a unit should start right from day one collaborating with their intensive care team so that they'll have better outcomes, so that they don't have to reinvent the wheel or make the mistakes that we made in the initial phase. And this model is going to work better for them from day one, and it will prevent stress on them or on the ICU unit, and it'll be better for the entire team and for the patient.
Thank you. And Asya, I'll leave you to finish us up.
Yeah, I agree with everything everyone said. I'm kind of taking notes, but I think I would just add and reiterate that complex patients require complex teams. And that doesn't just mean the oncologist and the intensivist. It could be the other subspecialists if they have organ dysfunction, and the other members of the multi-professional team, so the nurses and the respiratory therapists. And I think importantly, we've said, but not emphasized, the role of the family as a member of the healthcare team. And it requires all those people to come together in order to make the best decision with the goal of improving the care of the child. And that's just necessary. That's part of routine care. That's not a special thing that you do for certain patients. That has to be part of the way you approach the routine care of these patients to have the best outcome.
Thank you, Asya. One thing that resonated with me, the multi-professional nature of rounds. And, I feel very lucky because we have pharmacists that joins us from the stem cell transplant team, as well as ICU, nutritionists, the nursing team from both sides when you're deciding when a patient is ready to leave the ICU and go back. And I couldn't emphasize how important that is to get everybody's input. And if you do it on rounds in this collaborative model, it's just so highly efficient. You mentioned earlier, Asya, the time difference, and this highly efficient rounding structure where everybody's there in a short period of time just saves so much time for everybody. And I look forward to seeing where our field evolves over the next 5 to 10 years and how our patient population changes, and hopefully how these models continue to adapt. So thank you all for sharing your knowledge with us today.
This has been a production of Open Pediatrics. You can find the resources and journal articles referenced in this podcast in the description. We have more podcasts like this one available everywhere you get your podcasts. Visit openpediatrics.org for more information.